morning, everyone, and welcome to our Grand Rounds. And this today is a very special Grand Round. It is the 27th annual William Winters Lectureship. And it's great to have Dr. Winters with us and a very special guest and lecturer. But before that, few housekeeping things for us. As you know, we're broadcasting live via live stream, Facebook, as well as YouTube. And I'm happy to tell you that we have exceeded 20,000 subscribers with 2 million viewers. So it's lovely to share knowledge with not only the country, but also globally in the world. And I know many people are watching now live. Just an announcement, a few upcoming conferences, the 5th Annual Houston Heart Failure Summit in February 7, the 3rd Annual Heart of a Woman, February 15, inaugural DeBakey Congress, February 26 and 27, and our 10th annual multimodality imaging that we're taking on the road. Nowadays, actually, we'll be in Florida and Fort Lauderdale, and that's in March 14 and 16. We'd love you to join us and have some time off and enjoy the surrounding, but at the same time, have some exchange of knowledge and imaging, which is core nowadays. Well, it is the 27th annual Bill Winters Lectureship. Dr. Winters, it's great to have you. We know you here very well. We know your contributions, and I know quite a few people in the world know how much you contributed to cardiovascular medicine. You're one of our leaders and probably founders and fathers of cardiology in the Houston area, but also a past president of the American College of Cardiology. And at the ripe age of 80, started, looking inward into this institution and into the city, and wrote amazing books. And I would really encourage you, if you look at cardiovascular medicine, to read his book about Houston hearts, because this was really the hub, and still the hub of cardiovascular medicine with Dr. DeBakey, Dr. Cooley, and so many other things. So, Dr. Winters, what a pleasure having you here. And we wish you the best and great health, and continue to come, and not only for the lectureship, but for everything that you're still involved in. What can I tell you about our lecturer today that I think I picked about almost 2 years ago, Paul, Dr. Ridker. Paul Ridker really, truly does not need an introduction. He is a trailblazer. He is an amazing individual, visionary, I think, that has been on a mission, I think, at least in my book, of being convinced that inflammation has some relation to cardiovascular disease and atherosclerosis. And if you look at all his contributions over the years, they've been truly amazing, focused on not only proving, but hopefully changing the paradigm of atherosclerosis as to only related to traditional risk of hypercholesterolemia, hypertension, and others, but that inflammation has something to do with it. And I think as of late, and you know very well, and I know he will be talking about it, that we do have a proof with his leadership that inflammation is very important in modulating not only the atherosclerosis, but also cardiovascular events with atherosclerosis. He serves as the Eugene Braunwald Professor of Medicine at the Harvard Medical School, and he's director of the Center of Cardiovascular Disease Prevention. Certainly his pioneering work, as I mentioned, have been in the area of inflammation, high sensitivity CRP that many of the cardiologists early on did not know maybe of its existence in cardiovascular medicine, interleukins, and truly culminated in the CANTOS trial in 2017, where there was a true demonstration that inflammation is indeed crucial and important in cardiovascular events. He has served as a trialist and probably the principal investigator and the chair of many, many trials. And I'll just mention a few: PREVENT, PRINCE, LANCET, JUPITER, SPIRE 1 and 2, CANTOS, PROMINENT, And he has been really he had 10-year term on the NHLBI Board of External Experts. He has received multiple research awards and honorary degrees, the AHA Clinician Scientist Award, AHA Established Investigator Award, the Doris Duke Distinguished Scientist Award, and probably the most scientific of all is the Time 100 Most Influential. He has been also the NIH Director's Astute Clinician Award and AHA Distinguished Scientist Award. He's been invited, as you can tell, many of the famed lectureships throughout the world. At the American Heart Association, Distinguished Scientist Award of the American Heart Association, the Masuri Lecture in Italy, and the last one is the Braunwald Lecture of the American College of Cardiology. We were yesterday at dinner and talking about various aspects of life and clinical medicine. I think he shared with us, and I think many of you would be sharing, that he is most proud of his son, Andrew Ridker, and talking about his family. Ridker said, this is an amalgamated word of a last name that is not very common, but Andrew, his son, is a novelist, and actually if you Google Ridker, you'll probably see his name first before his, and he was so proud of his accomplishments. So, Paul, we're really very fortunate and honored that you would give the 27th annual Bill Winters Lectureship.
Well, thank you, Bill, for the extremely kind invitation, plus for plugging my son's novel. That's always a good thing to do. I really want to begin by thanking Dr. Winters for coming out to dinner last night and for the books that you provided me. I told Dr. Winters I read the first 2 chapters last night, a history of your medical center. And it's quite extraordinary. I know a fair amount about it from people who worked here. Tony Gatto is a long-term friend and colleague. But to hear sort of the inside scoop on how things happen, who was who, and so thank you very much for that, and for the honor of being here today. I'm going to try to give a clinical talk this morning. I sometimes change what I feel like depending on things that are happening, and felt that would probably be the best way to do this today. This whole notion of inflammation biology can be approached from many different directions. For example, your own John Cook, who we're looking forward to seeing later today, has really looked at this from a very fundamental molecular direction. I've had the opportunity to work in my career with a lot of basic scientists who look at inflammation biology and vascular biology from a very different direction than I do. And for the young people here, I would say right up front that I'm an unusual researcher because I did start my career a long time ago at the bench, have not been there in years. But I actually spend more time reading Cell, Nature, and Science than I do reading JACC and Circulation. And that's just the nature of how my brain types works. But the idea, and Bill is getting at this, of how do you take ideas from that basic literature and see whether or not they make sense for patient care, is kind of the underlying story of this whole process. So let's see. Conflicts. I have lots of them. It's the way it is. My children, my son and my daughter, think that medicine's a little dull. And that's because Dad has asked one fundamental question for 38, 39 years, which is this question: can targeted anti-cytokine therapy reduce cardiovascular events and prolong life? This is a slide without that title that I've used in the Harvard Medical School Cardiovascular Pathophys course for 25 odd years. When I sat in those seats a long time ago, we were taught pretty straightforward: atherosclerosis is a lipid deposition disease. We now teach that atherosclerosis is a lipid deposition disease driven by an underlying inflammatory process. And so the students just absorb that. But for those of us in clinical practice, it hasn't quite made it to our daily way of functioning. And that's what this talk's really all about. For the students, the idea that some patients with a grandparent or someone with rheumatoid arthritis is a very easy model of systemic atherosclerosis because you can see it. The difficulty for atherosclerosis is we can't see the inflammation in that sense of the word, and so this is a very visual approach to that. A couple of years ago, before CANTOS came out, actually, I wrote this editorial about residual inflammatory risk, a clinical concept that's been used by us and others now to really express this to our clinical colleagues. My clinic is pretty much an atherosclerosis clinic filled with patients who have hyperlipidemia and elevated levels of CRP. They all get a statin, virtually all get a high-intensity statin so that Peter doesn't call me and say increase the dose of the statin. We used to classify people simply as residual cholesterol risk. The LDL hadn't come down low enough. If it's still above 100, maybe you'd put them on a PCSK9 inhibitor, ezetimibe, or bempedoic acid, whatever your favorite is. The argument I'll try to make today is that that's great. We should do that very aggressively. But it's missing a huge part of the clinical opportunity, which we are calling here residual inflammatory risk. Notice the LDL here is now down to 70, which is low enough for me. And the question is, what else should be done? But in 2016, we didn't have any proof. That proof would come in 2017, and I put these two papers side by side because they really reflect a remarkable year for atherosclerosis research. On the left, of course, is Fourier, one of the many PCSK9 trials. Could have been Odyssey, could have been Spire, just happened to pick Fourier. You get about a 15% reduction in major vascular events by taking LDL cholesterol down as low as we can go with our current armamentarium. Terribly important, right? But in some ways, a little bit of disappointment because many of us thought that if we got LDL down to 15 or 20 on a chronic basis, we could really eradicate this disease. The right-hand side is the data I will be talking about in more detail, and all I want you to absorb right now is that the magnitude of risk reduction is exactly the same. But this is not the 30th lipid-lowering trial. It's the first inflammation-lowering trial. And so I was as surprised as anyone that the magnitude of risk reduction was just as large as it was elsewhere. Good morning, John. We just talked about, I'm not going to give a basic science talk, I'm going to talk to you about that later today. So this is where the clinical application piece started. I was working at the time with Charlie Hennekins, who many of you know ran the Physician's Health Study. If you take aspirin in primary prevention, that's why you do. And I was very lucky. And so again, for the young people, I highly recommend luck in a scientific career. It's very helpful. I was lucky because I was interested in this inflammation biology issue for a number of reasons I won't go into. We had this biomarker we could use, which you know of as high sensitivity CRP, but Dr. Hennekins, who I had played tennis and squash with, so again, your athletic part of your life is very important for your academic career. I knew he had run this study and he had banked these samples away when I was a medical student, and I called him on the phone and said, are they still available? He said, yeah. And so we measured CRP in healthy middle-aged men. This was important because the idea was that inflammation is not a response to ischemia. That had been discussed for years. Work from Attilio Mazzari and others for many years talking about that idea. This was important because it said that the inflammation preceded by decades the onset of the vascular event. And that was the trigger that said, perhaps this is a risk marker, a risk factor in the canonical sense of the word. And the lucky part was this was a randomized trial, double-blind placebo-controlled trial that Dr. Hennekins had run of aspirin, an anti-inflammatory drug. And beyond its platelet effects, we observed what you see in the lower left-hand corner, that the magnitude of risk reduction was greater if you had a higher level of inflammation with aspirin. And that would basically start this entire process for the research group. It's very important to understand up front that CRP is just a downstream biomarker. It's convenient, it works, but it's not the target for any of the therapies that we're talking about today. This is data that we published, 20 years ago now, saying, look, we think the target is somewhere in the cytokine cascade. We started at IL-6. It won't surprise me if we actually end up at IL-6 down the road, and I'll talk about why. But this was really important that baseline IL-6 levels, which we don't have a clinical assay for, by the way, which is too bad, are highly predictive of future vascular events. This is healthy men. We repeat that in healthy women. We published a series of papers between 2000 and 2003 or so, looking at a whole host of inflammatory biomarkers. Again, those of you who work closer to the bench will recognize ICAM, VCAM, E-selectin, IL-18, et cetera. The clinical point of this was that all of these markers of innate immune function, one way or the other, were elevated in our very patients at highest vascular risk that we thought were being lost a little bit in the guidelines discussions and lost a little bit in terms of clinical care. I'm as surprised as anyone that 30 years into this, the CRP data is still the clinical standard. Never thought that would happen. Turns out, again, that's a second piece of luck, that we simply had measured the downstream integrator of all this very interesting upstream response, and that the variability in CRP, which is a problem, was overwhelmed by the biologic signal upstream. And so that ended up being clinically useful. So what you see in the background is the clinical expression of this. The right-hand side is quintiles of LDL cholesterol, obviously a very powerful predictor of risk, and our primary target for therapy. On the left is the quintiles of CRP. And the most important observation was you can't predict A from B. They're different components of this integrated biology where inflammation and hyperlipidemia interact with each other to give ourselves clinical events. One of the most interesting things I had to go through was sort of understanding how to deal with a commercialized product. Again, not something that we ever thought we would have to deal with. But in the late 1990s, the automated assay for this came out. This is really the work of Nader Rafai, who's a very talented clinical chemist. We were talking last night, so he's my Syrian friend. And you can see here these early promotional things for CRP. The one on the lower left is the most realistic one. It's either a clinician or a scientist or even a patient looking through some microscope or telescope at a heart on fire. I think the artist kind of got the basic issues that those of you at the bench are struggling with. What I want to argue today is not that the biomarker is really what we should be thinking about. On the right-hand side was the clinical use of it. It's that if we drive this process down, the same way we might lower blood pressure, the same way we might lower LDL, can we actually drive down this inflammation? The answer to that is yes. Will it actually benefit our patients? And that's the much more complicated piece of the whole story. By 2010, there were 50 or 60 other epidemiologic studies that had replicated what we had found. It's one of the good things about the epidemiologic world is people do lots of replication. And this was the first meta-analysis that really was importantly done. And its take-home message was crucial. It said that whatever this per standard deviation increase in this inflammatory response, as measured by this pretty crude marker, was at least as large as the risk associated with hyperlipidemia and blood pressure. This would be the genesis of all of our grants for the next 15 years to the NIH, arguing we need to target this process to understand how we get beyond only the fabulous results we know we'll get from lipid lowering and blood pressure control. The story is being told a little bit out of order because at the time, in the mid-1990s, and again, this is a third piece of luck that I highly recommend for the young people, my catty-corner neighbor was a guy named Mark Pfeffer, who many of you know from the heart failure world. And Mark and Frank Sachs and Gene Braunwald had done the CARE trial, one of the relatively early statin trials, secondary prevention trial. And again, I said to Mark, you know, do you have samples? He said, yeah. We ended up measuring them. And so this is 1998 on the left, 1999 on the right. These are the first demonstrations that statins are anti-inflammatory drugs. These were clinical demonstrations. This is not bench work. This is patient work, saying, look, if you gave a statin, pravastatin, the relative risk reduction and benefit was far greater in the presence of an inflammatory response. It was either high CRP or high serum amyloid A. And a year later that the drugs were capable of lowering this response independent of their LDL effects. And for those of you in the lipid world and those of you who are a little bit older, you remember the controversy around this because this was sort of very much at odds with many parts of the way we taught atherosclerosis. And so this was a very interesting way to deal with this entree into the therapeutics that might eventually impact upon this. Tony Gatto actually was important in this story because he had his AFCAPS TechSCAPS trial. Those samples were actually stored out here. We sent a truck out here. They were shipped back to Boston, measured the CRP levels. And we published a paper with Tony that said maybe there was a way to think about modulating this inflammatory response among certain people with statins. That led to the data you see on the left, which is from 2005 in the Prove It trial that said, look, if you're going to give a high-dose statin as compared to a low-dose statin, you do much better. The red survival group here are those who get the LDL down and the CRP down compared to those who get neither down. On the right is data from a decade later, my colleague Aaron Bahula in the Improve It trials. Remember, that's ezetimibe plus a statin. But the population biologist says when you see data this consistent, you know, maybe we need to pay attention to it because it's telling us that our clinical guidelines, which of course now have LDL back in them, thank goodness, need to think more broadly about the elegant biology being done, again, by many of you in this room, and the translation of that to clinical practice, that maybe we need to be thinking about the inflammatory response as well as the lipid response in this process. This was a slide that I actually just put back in last night after our discussion with Dr. Winter, because we were talking about how things that make sense to an investigator may not make sense to others. This is a slide from the New England Journal from 2005 that the editors wanted me to take out, and I absolutely insisted it stay in. And they said, but Paul, it says absolutely nothing. And I sort of said, well, that's the whole point, that there is no relationship between your on-treatment inflammatory response, your on-treatment CRP, and your on-treatment LDL. They don't relate to each other. And until we get people to understand that, we're missing the whole point of this biology. I was out here in 2009. Dr. Willerson had me out across the street to talk about the Jupiter trial. I'm going to take care of that in 2 quick slides. This was not a test of the inflammation hypothesis of atherosclerosis. It was a necessary step along the pathway to get there. This was simply a study that said, if you would never receive a statin under any guideline concurrent at the time. So we started in 2001 when the guideline said in primary prevention, take the LDL from 160 all the way down to 130 and do not go below that because that was scary. That was 2001. We said that doesn't make sense biologically. We designed a clinical trial where the average LDL native untreated was only about 100 to begin with, but the CRPs were all elevated, gave them a powerful statin at a high dose way back then, and we get this very large benefit. I am a biased researcher. If you're not a biased researcher, something's wrong. If you don't believe in what you're doing and push on it, it doesn't quite work. So I look at this as, of course we got this very large risk reduction. Of course it's larger than the other statin trials because we actually maximized what the drug really does. We got all the lipid lowering benefit, and then we managed to figure out a way to enforce it among people who needed this secondary benefit that might not be lipid lowering. So that's how I've always looked at this. The good news is, as you know, the guidelines changed and we now treat virtually everybody with even the smallest amount of hyperlipidemia with a statin, and that's great. One of the things that's forgotten from this study was this is the venous thrombosis data, which was terribly important to us biologically. Prior to this, no statin trial had tracked venous thrombosis, but I started my career, again, at the bench thinking about inflammation and fibrosis and clotting and the hematology of this. And we knew that we were giving 17,000, 18,000 people a systemic drug. The critical issue, of course, is there's no plaque to rupture in the veins. That's the biologic issue. And yet we got this 43% reduction in DVT and PE because we actually thought about how to take the biology from the bench, put it into a clinical trial, adjudicate all those endpoints. And since this came out, all statin trials since have shown, yep, this is true. And that's been really interesting to think about what are these drugs doing that's really not an LDL function, because this is really a coagulation issue. And of course, here at MD Anderson, this is a big issue. So the cancer patients are now receiving statins for this reason, because of their very high risk of venous thrombosis, irrespective of the atherosclerotic benefits. There are some guideline folks in the room who I've talked to about things over the years. It amazes me, it was only 3 weeks ago that we finally got a high LDL, low LDL trial done. But A, it was done in Europe, and B, it was done in stroke. And it tells us exactly what most of us always knew, which was, yes, please measure the on-treatment LDL and get it lower. So that's just for that piece of the audience. Now, the complex part of this is, and again, I keep thinking about John, trying to figure out how does innate immunity work at a very fundamental level, and how do you then take ideas about that and the risks that might go with that and the benefits that might go with that and the long-term consequences of that tension and deal with this at a clinical level. And so this is in the mid-2000s, the cover of Nature on the left, that is CRP, the large red molecule in the background. And we thought that the editors got it completely wrong. So it says here, aiming for the heart, CRP is a target for cardioprotective drugs. That's exactly what we thought you should not do. We never thought that CRP was a target. We thought it was a downstream biomarker of the cytokine cascade that was where the action sat, but that didn't stop people from developing drugs that would actually inhibit CRP itself. Those failed, and that's not surprising that they failed. So on the right is a cartoon from many years later saying somewhere in this upstream cascade is where we think we want to go. So this is a very basic cartoon that is my attempt to describe the biology that we've really been thinking about. So the NLRP3 inflammasome sits centrally in this system. Most macrophages that you have this innate immune signaling system. This is where a DAMP function and PAMP function is often expressed. Crystalline structures are foreign to humans. Gout is the canonical NLRP3 disease because circulating uric acid is not a problem, but when uric acid condenses and crystallizes, the body sees it as foreign. It activates this inflammasome. The inflammasome, through pro-interleukin 1 beta caspase activation into active IL-1 beta, secretes IL-1 beta locally. That will augment production of interleukin 6. Both of those have many direct vascular functions that are quite deleterious. The IL-6 as a secondary effect will go down to the liver and put out our biomarker, the CRP, our thermometer of this process. And with gout, you can attack this with a whole series of drugs, one of which is colchicine, I'll come back to, one of which was canakinumab, we'll come back to. But the cholesterol crystal was shown a few years ago to also activate this process. So those of you who work in the cath lab, and later this morning we'll go and open up lots of arteries and make patients feel much better, so good. You're showering this system with cholesterol crystals every time we do that, and that is activating the system. And so there's a lot of interest trying to figure out in that world, how do we modulate that pro-inflammatory response? There's an elegant literature about how atheroprone flow. Remember, this is where certain lesions form in the arteries as compared to others, which is a SRB2-driven activation of this process. And there are many other things that drive this inflammasome function. But the point was we had drugs that were existing that would target this pathway, and we had to guess which pathway it would be, but it ended up being a relatively good guess. So why this one pathway? This is, again, just an easy way of doing it. The upper left-hand corner, the black and white is a scanning electron micrograph of a peripheral artery. The rectangular structure is a cholesterol crystal piercing the artery, and you see the innate immune cell attaching to it. That's the visual expression of what we're trying to inhibit. The cover of Science is, again, it comes from an issue that really had to do with innate immune function. You see the cholesterol crystal in yellow inside the mitosis-prone plaque. And the lower left is the model structure of canakinumab, a drug that Novartis had. It's actually created by a guy named Hermann Gramm in the pharmaceutical industry that was labeled as an orphan drug for a very small number of children with overexpression syndromes of IL-1 beta. So at an enormous medical center like this, I'm going to guess you have maybe 30 to 40 children in the greater Houston area, maybe, that are taking a drug like this to treat their Muckle-Wells syndrome or their neonatal onset mixed inflammatory disorders, very rare pediatric rheumatologic conditions. So in around 2009, we had finished Jupiter, and as I said before, it was not as test the inflammation hypothesis of atherosclerosis. It used a lipid-lowering drug that had anti-inflammatory effects. So we could use that to leverage this idea with pharma, and Peter Libby got on an airplane with me, and Peter's been a very good champion in this whole process and very willing to put his sort of reputation on the line to move these things along. And we met with a very senior people at Novartis in Basel back in around 2009, early 2010, and said, look, you have this orphan drug that you manufacture. We think it might be a narrow scalpel way of actually addressing the inflammation hypothesis of atherosclerosis. We had a lot of concerns about what might happen if you inhibit innate immune function for 3, 4, 5 years. We had some reassurance, and the rheumatology community has been doing this for a long time, and the patients do reasonably well. But these were not patients with an overt rheumatologic condition. They had this underlying silent inflammatory condition, and would it be safe to do? Long story, we managed to convince them to do this. We randomized over the next many years 10,000 patients globally. Unlike Jupiter, which was primary prevention, this is now very high-risk secondary prevention. We were not going to give an anti-inflammatory drug to people who did not have the disease, and we only gave it to people who, after their angioplasties, after their high-dose statins, after their ACEs, their ARBs, their beta blockers, everything else we could do. So extremely aggressively given care. Still had a CRP above 2 because we wanted to focus this down to people who we thought might have this persistent pro-inflammatory response. It was really a conservative approach saying, can we target a therapy that people were most concerned about? The last introductory thing to say is we did not know what dose to give. We had done a large phase 2 and a 2B study that actually were uninformative because, as we would later learn, when you inhibit this inflammasome with drugs like this, you are taking out inflammasome function for months, weeks, if not months, even though the drug is long ago cleared. So there's a whole biology of inflammasome reconstruction that we're only learning about now. Suffice to say, we picked 3 doses. The 150 milligram dose, for those of you who might see a pediatric child with this, is the standard dose the kids get, but the kids are treated ad libitum. When they have symptoms, you treat. And we ended up giving this drug 4 times a year. So we just gave it every 3 months. We probably could have given it twice a year, just in terms of what actually happened. Anyway, so we do this experiment, and this is really a global experiment. What you see here is the biochemical readout. You see dose-dependent reductions in CRP. I could substitute for that dose-dependent reductions in interleukin-6 with no change in LDL, no change in HDL, no change in triglycerides, no change in blood pressure, no change in hemoglobin A1C. So the point was we're only going to alter this one pathway, very specific monoclonal antibody targeting IL-1 beta, and take out that one component. And what we got was where I opened, the same risk reduction that we saw in Fourier and Odyssey and Spire, but in the absence of any change in ApoB, in the absence of any change in LDL, all that was done was lowered IL-6, IL-1, IL-6, and then by proxy, the CRP downstream. So this is an important finding for the vascular biology community because we have what is the first inflammation reduction trial targeting this one process that actually delivered the promise that we were hoping for. The clinical trialist in me said, well, we need to do the traditional thing, which is look at all the various subgroups. Okay, men, women, younger, older, diabetic, non-diabetic, it didn't matter. If you were that right-hand blue person, secondary prevention, atherosclerosis, on all these good drugs we treat with, and the CRP is still above 2, you simply benefited from canakinumab. There was no subgroup that didn't benefit if you were in this relatively small group that we enrolled. But that's not what we were actually interested in. The bench-trained part of me was saying, let's do something biologically much more interesting and pre-specify in the protocol, not a traditional subgroup, but how did you respond to the drug? Do we have people with a greater inflammatory mediation and a lesser inflammatory mediation? And this was all written up in the protocol early on. I just give you the fundamental results here. We did this by taking the 3-month on-treatment CRP or the 3-month on-treatment IL-6 level. Remember, they've only gotten a single dose of either drug or placebo at that point. So right before they get the second dose, we draw another blood sample, and we simply defined responders as a greater than median reduction in IL-6 or a greater than median reduction in CRP, and this is what we got. And this is particularly interesting because it says, look, not everybody is going to respond to these drugs equally well. That's just as true, by the way, for lipid-lowering and blood pressure drugs. But you can actually get a pretty good readout on who's going to benefit. Just focus on the IL-6 data on the right-hand side because it's probably a little bit cleaner. Why? Because it's one step closer to the actual target. Those who get an IL-6 reduction greater than the median at 3 months are having a 36% reduction in major vascular events. Those who did not, they're still getting a benefit, but it's really quite small. There's a piece of biology I'm fascinated by here. Payers were fascinated by this. They were saying, this is a new way of thinking about expensive drugs. Maybe we can actually figure out a way to actually give them to people who benefit and not give them to all these other people where it's not benefit. And there was a large debate about that at the FDA, which is a very different issue that I want to talk about today. But this idea of targeting drugs to people who actually respond to them ended up being very profoundly important for mortality. So this is cardiovascular mortality on the left in the responders and all-cause mortality on the right. And we're seeing benefits at 6 and 9 months, which is only 2 to 3 doses of the drug. Now remember, in the lipid-lowering world, we have to treat for years to see mortality benefit. Clearly does work, but long-term therapy. This is very quick. So there's something else going on here, modulating these plaques, changing their characteristics, that's quite important, which is what the message really is today. Now, I remember when Doug Mann was here, and then I remember when Doug went to St. Louis, and Doug was really a pioneer in thinking about inflammation and heart failure. And many of you know some of the very early stages of heart failure, it did not work. Doug's initial attempts were with TNF inhibitors, which was probably in retrospect the right idea, but the wrong drug to select. We knew that history, and this is work published by one of my colleagues, Brendan Everett, using our work. This is incident hospitalization for heart failure in CANTOS. It's not an overwhelmingly positive signal, but it is positive, and it's the first time we have evidence saying that at least if we do, again, this thing that doesn't change anything else, but just alters just one pathway, we do get some benefits on HHF. Regrettably, I cannot tell you whether this is HFpEF or HFrEF. We don't have the echoes, and so that whole process is now going to have to be done on a prospective basis. For those of you interested in a little more of the biology of this is a review written just a year ago for those of you who want to perhaps delve deeper into the reasons we did what we did. But what I want to do is give you an expression of why you can't use this drug and what actually happened. So when we started this trial, and again, I said earlier that I read way outside my typical literature. I just find it more interesting. And I was aware of literature in the cancer world that's summarized in this one slide here about the commonalities between wound healing, which is really what atherosclerosis is at one level, and invasive tumor growth. Suffice to say for the purposes today that inflammation in the tumor microenvironment have been recognized by our oncology basic science colleagues many years ago as being crucial for the growth, promotion, invasion of certain kinds of tumors. And again, to take a very complex field down to almost 30-second bullet, mostly tumors like non-small cell lung cancer. One of the reasons smoking is so bad for cancer is that you have chronic inflammation in the lungs. That's a chronic activation of NLRP3 in the lungs, and you're putting out a lot of this IL-1 process. We knew that. And so when we designed CANTOS, although the sponsor actually forgot we were doing this, which is interesting because Novartis is the world's biggest cancer company, but we were talking to their atherosclerosis people. We went ahead and established an oncology endpoint committee in this trial at the very beginning because we were interested in this issue. Anyway, in 2017 at the ESC, where you're given all of 10 minutes to present 10 years of work, we had to figure out a way to get the cancer data presented because we were publishing on the very same day. The atherosclerosis data came out in the New England Journal and the cancer data came out in the Lancet, and how do we do this without having another meeting? So at the end of that lecture at the ESC, I showed 3 further slides and oh, by the way. So this is the by the way. This is incident lung cancer, placebo, low dose, middle dose, and high dose. And here's a 67% reduction in incident lung cancer. And what's perhaps more extraordinary is that this is a 77% reduction in fatal lung cancer. If you look at the highest dose, you see no fatal events at all in the first 2 years. This is not oncogenesis. This is a randomized, double-blind, placebo-controlled trial of middle-aged and older people who have an underlying distribution of as-yet undiagnosed cancers, lung cancer, colon cancer. They're just small tumors. Over the next 5 years of their lives, some of these patients were unlucky enough to express those tumors, but those who were more lucky to be actually randomized to active canakinumab had a radical change in their outcome. This has completely changed the trajectory for this particular drug. And so I show you here what you can pull down on the federal website. Novartis has not abandoned this drug. They've simply radically changed their priorities. And this drug is now being evaluated as a potential adjunct to PD-1 inhibition. It's being used as an adjunct for a variety of things. I've talked to many of your colleagues at MD Anderson about what this means about innate immune function in cancer. And it's been actually quite interesting for us to learn about a whole other field. And this was not serendipitous, but it just, again, gets back to this idea about thinking beyond the disease that you know best. Now, it would be very convenient to give this lecture and sort of pretend everything worked, because it just doesn't work that way. Simultaneous to starting CANTOS, we really did not know for certain the IL-1 pathway was the right pathway. We had a very good reason why we wanted to do it. But we also were hedging our bets and said, well, look, I'm going to design a second clinical trial that you know as the methotrexate trial, the low-dose methotrexate trial. This was done with funding from the NHLBI, because at the time, we were uncertain about how specific we wanted this inflammation inhibitor to be, and we thought, well, look, maybe we'll also pick a broad-spectrum anti-inflammatory, very inexpensive drug that had observational epidemiology suggesting that patients with RA who got this drug did better from a vascular structure. Summarized it in a single slide because failures are quick. It didn't work, but it's why it didn't work that was so informative. So it's not simply that giving people low-dose methotrexate for 5 years had no effect at all on their vascular events. It also had no effect at all on their lung cancer. It actually increased the risk of non-basal cell skin cancers. But more importantly, no effect whatsoever on IL-1 beta, IL-6, or CRP. It did not affect the pathway that we now know is not the only pathway by any means, but at least one proven pathway of this process. So we actually thought this was a very informative null for the field trying to move forward. So we're back to this cartoon. And the question is, how do we get from here to the clinic, and how do we actually express this in a way that might work? And let me take you through a little bit what's going on. The first is colchicine. So colchicine, as a cardiologist, I've probably prescribed, I don't know, less than 10 times in 35 years, usually for pericarditis. and usually at fairly high doses for a couple of days, and people's pericarditis sometimes got better. Our rheumatology colleagues use it as a second or third line drug for a variety of rheumatologic conditions. It's a drug that's been around for hundreds of years. This study was published in JACC a couple of years ago, giving low-dose colchicine to patients with atherosclerosis. It was a small study, 500 patients, only 50 total events. It's a single-center study. It was not double-blinded. It was not placebo-controlled. So a lot of people said, well, hypothesis generating at best. But you should know that colchicine has multiple pathways for its anti-inflammatory effects. It's not a clean drug the way a monoclonal antibody is, but one of those pathways does include inhibition of the NLRP3 inflammasome. So you're probably aware at the most recent heart meetings, the Colcott data presented by Jean-Claude Tardif and his international collaborators, a study again of secondary prevention, 15 days on average post-myocardial infarction. It's an interesting choice, so these patients are in the middle of their acute phase response. So we can't use this study to think about biomarker data because all the biomarkers are going to plummet. So the placebo CRP drops here is probably going to be 85 or 90%. But they gave the drug in that setting. Patients were exactly who you'd expect, well-treated, aggressively treated patients, no problem there. And what they published was a reduction in hard vascular events using low-dose colchicine. We find this fascinating. The side effect profile in this trial was not bad. Patients tolerated their GI issues far better than people thought they would. It's hard to know what to do with these data, but it is now the second major study that shows if you modulate this anti-inflammatory pathway, we get outcome data that certainly we have to pay attention to. The really good news is that they hit this on their primary composite endpoint, which is shown at the top, with a little bit unusual endpoints: MI, stroke, cardiovascular arrest, urgent revascularization, cardiovascular disease. That probably was a good idea because the hard MACE endpoint, while it was in the right direction, a hazard ratio of 0.85, is actually not significant. Most of the subgroups are not significant. The great majority of benefit in this particular trial was on revascularization. So many of us would say, well, let's get a replication of this and see what's going on. We don't have to wait very long for that. So at the ESC this year, so in August, the results of another large trial called LIDOCO-2. This is being done by the same folks who did that original low-dose colchicine trial, but now in a proper multinational, multi-site, double-blinded manner. 5,000 patients there. Salim Youssef and his group up in Canada are in the process of something called Clear Synergy, which is a 2x2 factorial, also has colchicine data. So within a year or two, we'll have replication or not of this second phenomenon. And I would argue if we get replication, I think clinical guidelines might say, well, here's a very inexpensive drug. We don't necessarily have to know how it works, but it worked. And maybe we should think about that as the first drug to maybe enter our guidelines for treatment. Where's this field going to go is much more interesting to me because this is an open field with lots of opportunity. So this is a cartoon that'll be out in a couple of weeks that is describing, again, a little more detail about the various places you could go. I need to just slow down a little bit here because when you inhibit the NLRP3 itself, we did it, or we were trying to do it because we wanted to get IL-1 inhibition. So we gave a monoclonal antibody at the IL-1 level and not change the NLRP3 function itself. That may have been a good idea, a bad idea, we'll learn. But if you did inhibit the NLRP3 itself, which can be done with many drugs, and by the way, colchicine indirectly does this because it's a microtubule inhibitor, and therefore the structure of the inflammasome itself has a hard time assembling. It's a very different way of getting there. You also activate interleukin 18. And there was a big debate about whether this might be good, might be bad. And I think I have the slides in here. If I don't, I'll tell you it's actually probably good. But I hope I have it in here. But the point is there are many drugs that are actually available already, particularly at the IL-6 level. There's a number of IL-6 inhibitors that are FDA approved for Crohn's, inflammatory bowel disease, and the like, and they may or may not be useful for this setting. They are here. Good. So, okay. So here's the experiment. We've just given an IL-1 beta monoclonal antibody to 10,000 people. We're below the NLRP3 inflammasome. So as you'd predict, we get dose-dependent reductions in CRP, dose-dependent reductions in IL-6. But notice that nothing happened to IL-18 at all because we're below the inflammasome. Does that make sense? Okay. So now the question is, what happens after we give the drug? So these are the on-treatment, the 3-month levels of interleukin-6 on top, highly predictive of MACE, MACE+, all cardiovascular events, cardiovascular death, all-cause mortality. But interestingly enough, the IL-18 levels, which we didn't touch, are also still predictive of future outcomes. And although the magnitude effect is not as large, we have interpreted this as suggesting to us that perhaps taking out both of these would be better. This is a little bit like thinking of, well, if I had a perfect lipid-lowering drug that maybe would target ApoC3 and LDL. I'd get both of these things at once. And in many ways, much of this leads directly to IL-6, which is the downstream step from the IL-1 inhibitor. I show again the slide I opened with at the top left. That was our original deal for IL-6 some 22 years ago. In the middle is replication of this over and over and over again. Population studies have shown that the IL-6 works. In fact, Christy Ballantyne from Baylor has shown some of this work. The upper right-hand corner was the original Mendelian randomization studies published in 2012, saying if you had polymorphism in the IL-6 signaling pathways, that this paralleled the CRP change and paralleled the effect. The lower left is our NIH-funded work on population genetics of inflammation, again, just to show that the NLRP3 pops up as a fundamental determinant, not surprisingly, of CRP. And again, Peter has written an elegant review on this, shown at the lower right. And there are many drugs out there that can do this for us. And in fact, there was a FEWAS. Remember, what you're doing here is you're no longer putting the chromosomes on the x-axis, you're putting diseases there and flipping the whole situation. And if you just look up and down the tree here for the IL-6 receptor, almost all those red boxes, if you can't read them or not, they're aortic aneurysm, they're coronary atherosclerosis, they're atherosclerotic stroke, all the things that we deal with are all tied into this one particular loci, as is, of course, rheumatoid arthritis and things like that. So again, an attempt here to say, is this a rational target for treatment? So moving forward, we went back to our CERT trial. Now, this is the trial that did not work, right? This was the methotrexate trial. But the fact that it did not work gave us an enormous database of contemporary data where we already had all these markers measured. I just show you here the interaction between LDL cholesterol levels on the x-axis, the IL-6 levels on the back axis, showing the interactive risk. And again, it gets this idea of maybe we should be thinking about taking out both of these processes for our patients. And then finally, a little bit of future shock. There's other ways of doing this. This is quite interesting work. A guy named Kevin Tracy has been spearheading this for the last 25 years. He's a very interesting guy, interested in neurostimulation. But the reason for, again, the young people that your stomach gets upset when you go for an interview or doing something like that is because your brain is talking to your gut in a very real way. This is a schematic he's worked out with elegant underlying biology showing that if you stimulate certain parts of the neurocortex, you actually will change systemic production of IL-1, TNF, and the like. And there's a whole field in the lower right-hand corner here. My friend Charlie Serhan back in Boston thinking about lipoxins, resolvins, and many people around the globe investigating all these issues, which are all going to play a role in our field someday. So I'm going to go all the way back to the clinic to try to bring this to a close. This is where we started, but now we have these patients with residual inflammatory risk having at least two proven therapies. One you can't give, canakinumab, but that was really proof of principle, and one you could give. My own advice has been, I think I just wait. We're going to get a lot more data in less than a year. But for those of you with large clinic populations, we all know who the frequent flyers are, the patients that just keep coming back with a second and third angioplasty, multiple bypass surgeries, everything to do. Maybe that's a group that you want to think about taking this on if they have a high CRP now before the rest of the data comes in. What I do want to argue, though, is for those of you who don't measure CRP, and I've learned don't even ask for the hands to be raised because it's just always interesting to me. For those of you who don't measure CRP, you do not know what you're treating. You do not know what you're treating. Because I want to tell you there's 3 patients on the right for every 1 patient on the left. Now, industry is telling us, appropriately so, to get everybody's LDL down, and I certainly am a huge believer in that. But there's 3 patients on the right for every 1 on the left. And how you target these drugs matters. And here's the proof of what I just said. This is 3 big studies, Prove It, Improve It, and our own bococizumab studies on the right. That large swath, 29%, 33%, 37% in blue, that's residual inflammatory risk. That's what these patients have. The residual cholesterol risk is only the orange, 13, 14, and 7%. So again, yes, terribly important to get the lipids down and measured and know what you're doing, but I simply would argue, and I think the basic biologists who live their lives in this field would probably agree, look, we need to be thinking about inflammation as a target for therapy, and if you don't measure it, you can't think about it, and you can't treat it. PCSK9 inhibitors, fascinating drugs. These are extremely powerful lipid-lowering drugs. They may or may not have some anti-inflammatory properties. A lot of noise in the literature about that, but I will tell you they do not change IL-1, IL-6, or CRP. So these are the on-treatment levels of CRP in Fourier and Spire after they got either evolocumab or bococizumab, and it hasn't been touched. So I will argue that yes, wouldn't it be great if we could afford, get everybody lipid levels down in the 20s, but it will not eradicate this disease. We will still have this second piece of the problem. So we've been discussing with pharma for some time, let's not separate these two blue people, let's put them back together. We all recognize at a biological level that the inflammation and lipid pieces are actually very much functional to each other. How could we get there clinically? Well, there's two proposals we've put forward, neither of which terribly successfully so far, but we'll keep trying. One would be a 2x2 factorial. Take people, say, on a statin, randomize them to, say, inclisiran or to your favorite PCSK9 inhibitor, and then re-randomize them, say, to an IL-1 or an IL-6 inhibitor to see whether the joint effects are greater than any of the individual effects or greater than the placebo effects. That would be a very good way to do this. The right-hand side is where we might get to. That's a bispecific monoclonal, where you simply say, okay, we'll put a PCSK9 on this side of the molecule and an IL-1 or an IL-6 on that side. And the reason that has attractive nature is that's new product. It's new matter of material. And so industry is a little more interested in perhaps going that direction. Either of these might get us to a point in time, if they're positive, that we can bring these two worlds back together, and maybe we'll have a future where we treat most everybody with both these kinds of therapies. A couple of quick things. We can visually see this. There's many images here. We had a whole group of imaging folks for dinner last night. This is just one of many, many papers, happens to be from the MGH. The bottom is, of course, the ascending aorta, the spine, bone marrow, and the spleen on the right, and then all they've done here is ligated the coronary artery, and of course, you get light up with FDG PET in the ascending aorta. You get immediate lighting up almost after that in the bone marrow and the spleen. This is a visual expression of this whole issue of what they call the cardiosplenic axis, which we might simply say is the immune system being activated systemically by atherosclerosis itself. And clearly, this is something that we can monitor. Whether FDG PET is anything more than a glucose uptake, and actually an inflammation uptake is another debate, but the point is we can clearly see it. And last, I'm a preventive cardiologist. My clinic, and I also have a secondary also a Harvard School public health professor. I live in this funny world where we're trying to figure out how do we deal with this in the clinic. Short of these drugs, you can do almost all of this right now. I was being teased mercilessly last night at dinner because I had the steak. But we're in Texas. And I felt like if I'm gonna cheat, I better cheat here. And it was delicious. But it wasn't the best choice for my endothelium, and I know that. This is a much better choice. So those of you who had the fish last night, you win. So these are things that we can all do today that do have enormous benefit. There's an enormous literature on this. It's real. You really can alter immune function by simply having a healthier lifestyle. Same goes true for smoking cessation. Same goes true for exercise. Same goes true for weight reduction. This is a very interesting quote from Annette, Chris, and Ike Lotz. Now, these are molecular biologists. Ike Lotz is actually quite well known for his work on the NLRP3 inflammasome, but they published this very unusual thing 2 weeks ago in Nature Reviews Immunology, where they wrote, the Western diet appears to be mistakenly recognized by the immune system as a threat to the organism. I thought that was fascinating. And some of the data comes from clinical trials like Predimed, right? Because all this is a randomized trial done in Spain on top of a whatever Mediterranean diet might be, where they simply delivered to these homes a box of mixed nuts or a large jar of extra virgin olive oil, and we got benefit. We don't know, by the way, whether the benefit is because these drugs do have inflammatory benefit, they do, by the way, or whether it's just caloric substitution. Is it possible that because they were given free nuts and oil, they did not eat other things that were far more hazardous? We don't know that, but we do know it works, and that's the transitional part of the public health message. My kids travel a lot. They like yogurt. And this was a photo they sent me when they were out in Berkeley. Health benefits of Tutti Frutti. And down at the very bottom, it says reduces inflammation, which is remarkable because I can't tell you about anything else in that list. But it actually does reduce this process through some mechanisms that are quite interesting. The AHA has a nice randomized trial that was done between a vegan diet and AHA diet. So this is already getting a pretty good step 3 AHA diet. The vegans won. They got 30% lower CRP levels, 15% lower LDLs, and so I already admitted that I don't do this, but if I could do this, I would be virtuous. I do this. I'm very pleased that dark chocolate lowers CRP. I have to tell you a little story here, because many of you trained in Boston. The Harvard Medical School CME police did not let me show this slide at a CME course in Boston because they thought I was promoting Lindt chocolate, and they wanted me to take the photograph of the Lindt thing out. I put in my disclosures I did not have any grant money from Lindt, and I was not a consultant to Lindt, but it did not satisfy the CME police there, but it did satisfy yours, so thank you for that. Or they didn't notice. Yeah. This also upset the CME police in Boston. They actually thought I was showing this slide to promote McDonald's. So,
They do have salads now.
yes, they do have salads, and they have chicken. You have to actually wonder a bit about putting McDonald's across the street from a cemetery. But either way, just so you know, for those of you interested in why it's so difficult to control this public health problem we have, these are 10-year-old dollars. This is from another decade. So it's only, I assume, gone up from there in terms of the advertising issues that we're all struggling with our patients, who, of course, it's so much less expensive for them to eat at these places than to go out and buy fresh vegetables. And so government reform issues like that all play into this whole process. Last, what I think is really happening in the atherosclerosis world from a clinical translational point of view is this splitting apart of the patients. Our cancer colleagues long ago figured out that there are many, many, many different types of tumors done with tumor markers to figure out who really needs very specific things. And it's part of the genius of what's happening, for example, out here at MD Anderson. I think the atherosclerosis community has been behind that process, but is getting there. We no longer think of all the patients as being exactly the same. I think the statin era allowed us to treat everybody with everything. And so statins, beta blockers, aspirin, ARBs, et cetera, fine. We've talked about residual cholesterol risk. I've talked about residual inflammatory risk. The residual thrombotic risk is really complicated. We know from DAPT studies, we know from COMPASS that there are clearly interventions that lower that risk. What we don't have is any biomarker to tell us who needs it more than someone else. And until we get a biomarker, and all the coagulation markers, by the way, have failed, we have to figure out how are we going to pick who might get the therapy because there's risk and there's benefit, and balancing that's important. Triglycerides has really become complicated. So again, most of you are well aware that the REDUCE-IT trial using high-dose EPA surprised many people by being highly successful. And then just 10 days ago, the AstraZeneca-funded STRENGTH trial, of which I'm on the executive committee, put out a press release saying this trial was being stopped for futility. We'll get those data at some point this coming year, but that's a high-dose EPA that also has DHA in it. So either these two trials are completely at odds with each other, or perhaps there's something wrong with the DHA part, which there has been some discussion in the basic physics community actually about why that might be. I happen to be the principal investigator of something called Prominent, when we have quite a few sites out here, which is actually a selective PPAR alpha modulating drug called pemafibrate, which is sort of a second-generation fenofibrate, which does not have some of the negative effects of that drug, that lowers triglycerides by 45 to 50%, whereas the fish oils only lower triglycerides by 15 to 20%. And I think that entire field right now is upside down. We just don't know, and we'll have to figure that one out. And as many of you are aware, we're now, the greater community is launching a whole series of LPA trials. The point is, we're going to have to start measuring these biomarkers to figure out what's the underlying biologic problem that my patient in clinic has. How will I figure out who they are, and how will I get there? I know that, for example, coronary calcium scanning is very popular out here. It's fine. It's a good way to predict risk, obviously. But it doesn't tell us which bucket you're in. And that's part of my problem with that approach, is it doesn't really, it says, yes, my patient's high risk, but I already knew that. The question is, how do I use the information to treat them? And I don't know how we get there from that approach. And so I think we're going to have to stay with these ideas. I'm going to skip over that. And these are the three trials in that space. Our trial on the right is there. Whoops. So let me bring this to a close with just some summary issues here. I think there's 4 or 5, 6 things we can say with confidence, and then the question is, how do we move forward? First, the most important thing, atherosclerosis is a disorder driven by lipid accumulation and by inflammation. We now teach the medical students that, so we're past that. CRP is as strong a risk marker for heart disease as is LDL or blood pressure. It's got similar variability over time. Diet, exercise, smoking cessation, all lower CRP and all lower cardiovascular risk, so there's a broad message about prevention there. In primary prevention, we've now known for a decade, that's Jupiter, that if you have patients with an elevated CRP, they should be on a statin, even if LDL is low. Our guidelines have dealt with that mostly by simply dropping the thresholds for LDL, and I'm absolutely fine with that. It's one way of getting there, and that's absolutely fine. In secondary prevention, CANTOS gave us proof of principle that inflammation inhibition in the absence of lipid lowering can clearly improve atherosclerotic outcomes. And it's fascinating to see this transition from the bench to the bedside. This is the first hard evidence in 40 years of an effective therapy for atherosclerosis that's not directly related to cholesterol reduction or blood pressure or coagulation. So that's the good news of this story. Taken together, the positive CANTOS data and our neutral CERT data have really helped to define at least one pathway, at least this central IL-1 beta to IL-6 to CRP pathway of innate immunity as probably crucial for this process. Doesn't mean there aren't others, simply means this one seems to work. The new Colcott data provides, I think, a very important second affirmation of this whole hypothesis. It's less clean than the CANTOS study because of what the drug is doing, but it seems to be safe. It's far less expensive. It's an easily taken oral agent. And again, toxicities seem to be pretty low. If the ongoing trials also give similar results, and if we can figure out it's not just revascularization, but the whole process, I would be pleased to see something move into guidelines that we could use for patients that is inexpensive, and we might get there within the next year or two. My own bias, I think quality cardiovascular care requires us to recognize this distinction between residual cholesterol risk and residual inflammatory risk. Yes, there's a big overlap. Yes, many patients have both, but I don't want the patient with only lipids to be ignored any more than I want the patient with only inflammation to be ignored. I think we have to recognize that different biologies are at play here. Future trials of inflammation inhibition are likely to focus on alternative IL-1 targets. There's 5 or 6 other kinds of ways to inhibit that. You can give an IL-6 inhibitor directly. You can target the NLRP3 upstream. And for those of you in this field, you know there are 6 or 7 companies now that have targeted NLRP3 drugs. And the tension is, do they go after the low-hanging fruit and get labeled for these rare immunologic diseases, or do they actually go after a large population of patients? And that's quite complicated. But I actually think that it can be anticipated based on the fundamental biology and this sort of translational story. I would predict that almost all atherosclerosis patients down the road, when we figured all this out and it's inexpensive, will probably get a combination of both of these kinds of approaches. So this is sort of the slide I show at lipid meetings. This is the canonical LDL lowering line. Every statin trial always falls in this line. Percent reduction LDL on the x-axis, relative risk reduction on the y-axis, and way off on the left, no percent reduction LDL. 2 trials now saying, yep, there's something else we actually have to pay attention to bring this to clinical fruition. This is my last slide, and I show it for a very different reason. I did not want to be a clinical trialist. It's not what we ever started out doing. It became apparent, though, as someone trained in fairly basic biology and then translational sort of epidemiology, population biology, that trials was the only way to actually change practice. Trials was the expression of when the clinical community says, got to listen to that. Trials do not get done by any one person or any committee or any group. They get done by the physicians and the coordinators around the world, and this is one slide of 17 I could show you. I always have shown these slides at my investigator meetings, of the kinds of people who actually make the enormous contribution here. I think that we forget sometimes that when a patient comes to us as their physician, they're actually coming to you for your expertise, your knowledge, your advice, your belief. And then you say to them, I have no idea what to do. I'm going to let a computer 5,000 miles away randomize you to A or B. And the patient says, I trust you. Okay, that's fine with me. That's remarkable. That's a fantastic relationship between a patient, a physician, his or her coordinator. And I think that's what this process is about. So as a larger pitch, and getting back to some of the things that Dr. Winters and I talked about last night about how medical process gets made and the trust that's involved, this is terribly important. And I think I just want to make sure people understood that please do enroll your patients in clinical trials. It's the only way we can take the core biology and figure out if it's actually true. Bill, thank you for having me here. It's a pleasure to come back to Houston. And thank you, Dr. Rivers. Thank you.
Paul, that was really fantastic tour de force of a history of more than 40 years of from concept to proof, and much more work to be done. On behalf of all of us here at Houston Methodist and the DeBakey Heart Center, just a token of appreciation to the lectureship, Dr. Winter's lectureship on the 27th anniversary.
Thank you very much. Thank you.
I'll take a question or two. I know we're late, but a question or two. Dr. Phillips.
Well, in CANTOS, it looked like there might be
Can we have a microphone, please?
a gender interaction. I'm just wondering whether it's oftentimes, like in a lot of trials, women don't respond in the same way.
So in CANTOS, we saw statistically significant benefit in the women as in the men. It's a little smaller in magnitude, but I don't think it's statistically different. So I'm not sure we have an issue there. Of course, the women are about 10 years older because they had to have a prior event.
Paul, just fabulous. Thank you so much for coming and sharing this with us. Two questions that I know the answers will be complicated, but just very short. Is anybody now beginning to work on the genetics behind all this? Because obviously not everybody has high inflammatory stages. So is that something that's cooking, number one? The second question is, there's a lot of interest in stress and heart disease and heart events. And now we know that when the amygdala gets stimulated with stress, there is a whole cascade of reactions that increase a bunch of promoters for inflammation. Again, could this be part of that equation that so many smart people are working on in trying
Yeah,
to?
so Miguel, it's not surprising me at all that you'd ask two terribly thoughtful and important questions. And the answer to both is yes. The very short answer. The somewhat longer answer is the genetics of this is actually fascinating. So there are enormous studies coming out of UK Biobank and elsewhere, clearly showing that polymorphism in a variety of these pathways, particularly the IL-6 signaling pathway, which is what's so interesting about that piece of this, are actually a rather powerful determinant of outcomes. Now remember, even the multi-genetic risk scores, which work quite well, only move your risk a little bit. So the genetics is informative for the biology. Clinically, it's still hard to figure out what to do, but the answer there is yes. The stress part of your question is overwhelmingly interesting. Our research colleagues in neurology and psychiatry have been making this argument for a long time. And I think, to be honest, we probably underestimated the work they were doing, because looking back on it, yes, there's all sorts of interesting changes in lymphocyte function and immune function under stress, under different kinds of stress. And clearly there's an excess of disease in those settings that improves when that stress, however it is removed. The field got a bad name a few years ago because people tried to take that idea and give them drugs. So there was a few clinical trials of antidepressants that were just complete failures. It didn't do anything. And that unfortunately biased this field. But I think in retrospect, figuring out why it is that humans under tremendous stress, whether it's fiscal stress, financial stress, relationship stress, those sort of things, they get sicker, they get more of these events. I think that's real, and we do need to figure it out.
Last question, John.
Paul, that was spectacular. Thanks so much for coming. You focused appropriately enough on large vessel disease today, atherosclerosis. Tell us what you're thinking about the application of this therapy or this approach to microvascular diseases. And one I'm thinking about is vascular dementia. What can you tell us about that?
Right. So John, right before you walked in at the very beginning, I mentioned that that among others, your work thinking about how this whole thing fits together, and what are the negative aspects that might come with chronic inhibition, and what are the positive aspects. We actually have a whole series of papers, which I'll chat with you about later today, that have to do with the other things that happened in this trial. So just really rapidly, we've got a 25% reduction in the anemia of chronic disease. We have a big reduction in gout. That makes sense. It's an NLRP3 inhibitor. We have a 45% reduction in osteoarthritis. That's simply looking at the adverse event forms, asking the question, did you have a hip or a knee replacement during the trial? That's all it was. And there's a whole literature about what IL-1 means for OA. The cancer data you're well aware of. The heart failure data we talked about briefly. The microvessel process we looked at, the only one we looked at carefully so far was kidney function. It's not quite micro, but it's getting there. And what we showed there was that patients with chronic kidney disease get a much larger than people with normal kidney function benefit of being on the drug for vascular events. But we actually did not improve renal function over time, which is why we had done the experiment, given literature I know you're aware of about NLRP3 function in microvessels within the kidney. You're really asking about cognitive function, which is the holy grail of this field. We were unable to secure funding to get cognitive function testing done at the beginning and the end, and I'm not sure that in a 3.5 to 4 year period it would have been enough to see it. And as those of you who do cognitive testing know, you really have to focus on a group of people who are probably 65 or 70 and over to kind of focus in on people who have the underlying thing. But my bias would be that, yes, this would be a very smart way of going after this. And the NIH is thinking that way in terms of how do you bring to bear really all these things are disorders of aging at one level. And how do you think about that in a more sophisticated way? But I look forward to chatting with you later today for that very reason, actually.
All right. Well, with that, I think.
Real quick.
Okay.
So, as an electrophysiologist, I don't measure CRP, but there's some emergence data on the hypothesis that some forms of atrial fibrillation arise in the context of inflammatory response. I wonder if in the CANTOS or any
Yes.
of these trials you've seen any
Yes,
impact.
so we're well aware of literature that says things like IL-6, things like CRP have predictive value for various SVTs, in particular AFib flutter. We don't see a benefit. For what it's worth, and I don't. That's all we have right now. And again, we didn't track it in a systematic way. We just have reports coming in.
So you still have work to do.
Yes, we'll be waiting for a long time.
Thank you again, Paul. Amazing. Thank you.